Welcome. I'm Renee Nicholson, Director of the WVU Humanities Center, and it is my pleasure to introduce the first annual James and Shumway and Lizbeth A. Pyle Health Humanities Fund recipients. But first, a little bit about the fund. The fund supports opportunities for advancement in education within the fields of narrative medicine and the health humanities. Narrative medicine utilizes people's narratives in clinical practice, research, and education as a way to promote healing and aims not only to validate the experience of the patient, but to encourage creativity and self-reflection in medical professionals and those who collaborate with them. Narrative medicine is a subset of health humanities, an interdisciplinary field of study that draws on aspects of the arts and humanities in its approach to healthcare, and well-being. I would like to thank Betsy Pyle and Wesley Shumway and their family for their support of this fund, both financially and otherwise. Although Betsy could not be with us today, her support of the WVU Libraries and the WVU Humanities Center, who share this fund, is critical in building world-class health humanities here at WVU. In health humanities, the patient-physician relationship is a critical one, and so I am delighted to introduce an interdisciplinary team whose work impacts one of the keys to good relationships, communication. I affectionately refer to these first fund recipients as the pain group, because their work impacts patients who suffer from tremendous pain from difficult and often terminal illness. However, this doesn't characterize my interaction with the researchers, as this has been one of the most engaging and collegial interdisciplinary teams I've worked with. And I used to direct the programs in multi and interdisciplinary studies here at WVU. I really cannot say enough about the importance of their work. Comprised of physicians and literacy scholars, this group is unpacking opioid agreements, commonly called pain contracts, which are legal agreements with patients who are on a medically necessary controlled substance. The team includes WVU-based Dr. Corinne Lee Stewart, Penn State-based Dr. Monica Holbein, Dr. Stephanie Pockle, a fellow in geriatric medicine here at WVU, Dr. Amy Warwood, professor of literacy education in the College of Applied Human Sciences, and Canyon Lonas, a PhD candidate in the College of Applied Human Sciences. Specifically, the group's research focused on readability formulas, which are often used to determine reading levels. The team found that these formulas may not be capturing the realities of the content within the documents in healthcare and opioid agreements in particular. Given that healthcare professionals are taught throughout their training to use non-medical language to increase patient understanding, looking closely at the language and themes portrayed in medical documents like opioid agreements can affect good communication between patient and provider. The team's concern about these agreements is that in their current form, they may not easily be understood and thus not patient-centered. Their research led to an invitation at International Pain Week earlier this fall in Las Vegas, with several publications in the works. It's really my pleasure to introduce my beloved pain contract team, and I cannot think of a better group to be the inaugural recipients of the James M. Shumway and Lizbeth A. Pyle Health Humanities Fund. In 2015, I had the opportunity to work with Jamie Shumway, who helped me learn about the health humanities and narrative medicine as I helped him to write a memoir during the final stages of ALS. This work Jamie and I completed together forever changed the pathway of my own academic career, and for that I will be eternally grateful. Supporting new work in the health humanities and narrative medicine feels like the natural extension of Jamie's life and legacy, and I am honored to carry it forward through the Humanities Center. And I am also exceedingly pleased to host this group of researchers and believe we will learn much from their presentation today.
For that wonderful introduction. So I'm so excited to be here with this lovely group of people that over the past year and a half, we've laughed together so much on our phone calls. We've had such a good time going down the rabbit holes and eventually coming here. So we're here to present Reaching Across Boundaries, Interdisciplinary work between medicine and literacy education. So for context, this work came out of me looking at the opioid agreements that we had to do when we were prescribing opioids to any patient, including patients with terminal and life-limiting illnesses. And looking at them one day and thinking about, okay, so I'm talking at like a 5th grade level with my patients, as is the recommendation for us as healthcare professionals to make sure that everything that we say is understood. Then I looked at the opioid agreements, and I'm like, this is not that. So I turned to Corinne and I'm like, what's happening? Like, does this make sense? And she agreed that the level of literacy needed for the opioid agreements was, we thought, kind of high. And Renee, I called Renee at that point, and I'm like, I have an idea. I need help. And you're the person that I turn to when I need help and I need a connection somewhere. And you're good at words. So you must know other people that are good at words. So Renee hooked us up with Amy, who in turn hooked us up with Canyon. And I couldn't think of a better team to be working with. So we truly formed this interdisciplinary team. So it does really embody the healthcare professionals and Humanities Center and from the WVU College of Applied Human Sciences, because we were all working towards a common goal. And that's what interdisciplinary is really all about. We're working towards that common goal. So the purpose of this study and of this lecture was interdisciplinary research leverages the expertise of scholars within different fields and provides opportunities to consider the implications for their respective fields. Readability formulas are often used to determine rating levels. However, these formulas do not capture the realities of the content within the documents. And more to that later, because I think that when we looked at the readability formulas and read, there were many things that came out of that.
All right, so when we started this, as it started as many research projects do with an observation bedside. And then we started to develop some questions. What do you think? What do you think? And we couldn't answer those questions ourselves. But we needed some help with that. So that's what we're doing, and we're very thankful to have had her on this project with this group. She's pioneered the narrative medicine here at WVU, and was really the perfect person to help pull this team together. As she mentioned earlier, the humanities are sprinkled throughout our medical education, and obviously we deal with people every day. So the humanities play an important role in how we interact with our patients, how our patients interact with us. And again, what was beautiful about this is bringing these different disciplines together to figure out a way to better care for our patients. So that was pretty exciting. And with this graph, kind of where we landed was in the middle, where all these circles come together. So where does that put us? So we kind of figuratively fell into the medical humanities with this. Thankfully, it didn't happen literally. We definitely figuratively fell into medical humanities. And there's really not one unifying definition of medical humanities. There are multiple definitions of medical humanities. I've pulled a couple here to kind of to further explore what the medical humanities are. But it is a very broad, diverse, interdisciplinary field of study. So the National Library of Medicine defines this as the study of the intersection of medicine and humanistic disciplines, such as philosophy, religion, literature, and the fine and performing arts. The Health Humanities Consortium further incorporates social sciences into this. So things like anthropology, sociology, cultural studies, and history, in addition to the humanities, including theology, ethics, philosophy, and literature. When these are merged with healthcare, we are talking about medical humanities. The health humanities use methods such as reflection, contextualization, deep textual reading, and slow critical thinking to examine the human condition, the patient's experience, the healer's experience, and to provide renewal for the healthcare professional, and I think for the system at large, which incorporates the patients and the other researchers that are involved in this field of study. So I found this chart and I really liked it because I think it really nicely talks about everything that, in broad terms, that a physician has to think about when they're providing care to a patient. So we have the scientific portion of this, and we also have the humanities portion. And we're doing this during every single visit. Every visit. So we have to have a scientific understanding of the disease process that we're caring for in a patient. We have to understand scientific medicine, and we really are trying to practice evidence-based medicine. So we're giving our patients the best care possible. And this all feeds into our technical judgment, okay? And then on the other end, there's the ethics of what we do. We all take an oath to practice ethical medicine for our patients. And what is our educatedness? How much do we know about the topic, about the patient, about the patient's literacy levels, about the documents we're providing them? So that feeds more into the humane judgment when we're taking care of our patients. And then with interpretation and insight, there is both interpretation and insight into the scientific portion of what we do and the humanistic portion of what we do. So that feeds into both, and all this comes together with the technical judgment and the humane judgment to form our clinical judgment, and to provide patients with the optimal treatment plan, and to care for them as human beings, which is so important. And I think, for Dr. Holbein and I, it's the foundation of what we do. So it's so important. So I thought this was a very nice flow chart to kind of lay out what all goes into our clinical judgment.
Okay, so I am Amy Morwood, and myself and Colin, or Canyon, excuse me, sorry, Canyon, we both come from K-12 backgrounds, and so it was really interesting to jump into this content area and be on graduate school and things that our students that we work with. I'm going to speak here about the flow chart that we also put in here about our interdisciplinary work that we're specifically talking about here. We'll also speak about our readability formula information, and also our content analysis that we did of the contracts. So we started here with, we started off with this flow chart here with the methodology of interdisciplinary research framework. It's known as the MIR. And we started off with the research objective here to determine the readability of opioid agreements. That's where the conversation began for all of us. And then we moved through this flow chart, and you can see that the next step there is the general research questions, specific research questions. And ours for this initial project was, how are readability formulas used to evaluate the reading difficulty of opioid agreements? Then we moved to the study design and we did a case study because we looked specifically at WVU's contracts and agreements. Then we moved on to data analysis where we analyzed the documents using the free readability calculators that we found. Then we moved on to sampling design, and that was the WVU contract and agreements and the sampling and the measurement there. The measurement, we used two different formulas. We used the SMOG, which is usually used in medical work, and then we used the Flesch-Kincaid, which is used in educational settings, so that we could compare the readability formula data between those two different tools, so that we could think about, are they different, and compare them across. Then we went over to the analysis and we looked at the scores. We moved over to synthesis there, which is the scores were higher than what we had expected and what is typically recommended within both the medical field and both the educational field. We weren't surprised by that. We were surprised by how high they were. And then we move up to the report section there, which is dissemination. And we, as Renee spoke, we did a presentation at Pain Week in the medical field. We've done a few others in the area of literacy education as well. After the report out and the dissemination, we moved up to that next part of the flow chart there, which talks about theories and models. And we started thinking about how do we situate this work in the literature that's out there beyond the initial literature review that we had done. So moving into that more theoretical line of thinking. And we were considering the autonomous model and also the area of health literacy, specifically through the CDC's definition of that. So the autonomous model basically says that if you learn a set of literacy and reading and writing skills, generally you can then apply them to all contexts. And then in health literacy, we brought in the idea of the fact that the onus of that really falls on the patient. The doctors and nurses and practitioners that help you within the constructs of the medical field provide you the information, but the reality is the patient is the one that has to take that on and own that. So when there's a deficit there of reading levels and the levels are high, you can see that there will be a disconnect. Once we talk through those models a bit, we looked at the constructs, which would be the reading ability and patient-centered care, which we talked a lot about in our conversations. We talked about reading ability. These folks over here talked about patient-centered care, and we tried to push those ideas together. We talked about the attributes and the instrument selection and the variables. So they're really thinking, we started thinking more about not just the numbers of the readability tools that came out, but the ideas of what were the words saying in those documents? What sort of vocabulary and terms were being used that would then create these high levels of reading scores on these readability formulas? Okay. So the readability formulas here, there are two documents that we learned that WV uses for opioid agreements and contracts. We split these up originally, and we did the first one here, which was West Virginia University's non-chronic pain contract for use of opioid medications. And we took the first 915 words of that contract. We used three free tools, so anybody would have access to these. We used Microsoft Word, readabilityformula.com, and textcompare.org. And you can see from the numbers here, the Flesch-Kincaid grade level for Microsoft came out at a 12.8 grade level, and then SMOG was not even, Microsoft does not score on the SMOG tool. And then for readability formulas, it was a 10.9, and that means it's grade level 10 in the 9th month. And then SMOG was 10.7. And then text compare again was 12.44 up to 15. So you can see there is a range even within this one document. Then we did the second document here, which was West Virginia University's consent to treat with opioid medications. We did 446 words of this. Again, we use the same three tools, and you can see here that the scores are again significantly higher than the recommendation that they spoke about and what we found in the literature. And then we did a combined readability formulas where we took the total documents, which was 1,361 words, and it averaged the scores. And again, there's still some variability amongst the tools and also between the two educational, the Fresh Kincaid tool and the SMART tool. Okay, this is you. Canyon, this is you.
Thank you. My name is Canyon Lotus. Thanks for being with us today. Thanks especially to this group and Dr. Morwood for bringing me along this ride. After we did the first layer of analysis, which was inputting the data into the readability calculators, we received the scores, and of course, somewhat unsurprisingly, they were higher than we expected. So we really wanted to dive deeper into the themes that would emerge through a content analysis of documents. So you can see on our interdisciplinary framework here that after the dissemination of those results, it takes us back up to theories and models and how those findings were contributing to the research in those fields. Eventually, it got us back to a new research question, which are what themes emerged during a content analysis of an opioid agreement. So in essence, what content do these documents actually contain that will inform the patient about the options available to them and the risks and benefits associated with opioid medication. In this next layer of analysis, we needed to change our methodology a bit. We stuck to the case study, focusing on the documentation here at WVU. Again, we sampled both the opioid agreement and the consent form. After that, we used content analysis using Krippendorf's methodology, and basically what a content analysis does is look for emerging codes in the documents. So codes are the smallest level of meaning that can be taken away from the language in the document. And we so we did a content analysis on both the contract and the agreement. The codes that emerged through those documents sort of served as our data points moving forward. During the analysis part of the research, we ended up taking these emergent codes and fitting them into categories and other areas and themes that would allow us to better communicate the information shared through this documentation. Through this research, we found 42 unique codes and classified them into 8 categories within 3 themes. So here we are, we can see the findings of the content analysis. These circles are sized to the themes that are most prevalent, or the categories that have the most codes. So you can see that the biggest one is administration. This was a category that we developed as a group that basically describes the sort of procedural level of information that patients need to know. Things include, directions for completing the contract itself, the necessary signatures required, as well as, just checking to verify that the questions that they ask orally have been answered. After that, there's good similarity between rules and adverse outcomes. You can see that the rules are setting the expectations for patients as far as the things that they need to follow through on in order to continue to follow the treatment plan as prescribed. Adverse outcomes refer to the anticipated risks associated with opioid medication. After that, we go to objective medication information, which basically describes what we've been referring to as the nuts and the bolts of taking the medication. So the type of medication, the quantity, the medication, the refill schedule, all fall into that category. Next, we have acknowledgements. These are just things that the patient is agreeing to by signing on the dotted line, so to speak. So things about agreeing to the conditions set forth, those expectations that we just mentioned. And next, we have punitive consequences. So these are the things that if you were to violate any of the rules or expectations laid out in the document, the potential repercussions of those things. Next, we have benefits, which you can see is a much smaller circle here, which was an interesting finding. And lastly, the availability of other treatments. You can see easily here in the visual that a lot of time is spent discussing the expectations for the patient and the potential negative consequences of opiate medication. A lot less time is spent discussing other treatments and the potential benefits of following that treatment. So that takes us, after the dissemination of those findings, that took us back to the literature. And you can see at the top of the chart here, we've now outlined those blue boxes in green to show that we are combining what we found through our analysis using the readability formulas as far as the actual reading difficulty of the documents with what we found about the meaning of those documents through the content analysis to give us a better informed idea of the reading difficulty of those documents overall. And we're using those findings to contribute to the literature in these spaces and reinform our thinking around these theories and models.
Okay, hello everyone, I'm Steph Vogel. I did internal medicine and palliative care training here at WVU. I'm currently training in geriatrics, and I'm going to talk to you all about some implications of our work so far. On the medicine side of things, we want to critically review medical documents with the patient and make sure that we're exploring and confirming their understanding when we're completing these kind of documents. And pay closer attention to the reading difficulty of our opioid agreements is necessary to increase patients' understandings of the documents that are associated with opioid medications. On the literacy side, we want to collaborate with the field of medicine to be more aware of the language and the reading difficulty of patient care documentation, and also develop a better understanding of the available readability tools and their applications to other fields, and also provide recommendations for accurate and reliable readability tools to other fields. For the implications of interdisciplinary research, the opportunity to collaborate with other schools within our university setting is invaluable, and we must consider that more often to be on the forefront of knowledge and understanding. The MIR offers a helpful guide for research teams to engage in interdisciplinary research, but we want to call additional attention to give a thorough review to the literature. And our Humanities Center provides opportunities for researchers within the natural and social sciences to collaborate. We really appreciate Renee bringing us together and really helping us bridge this from, a conversation between Dr. Goldine and Dr. Stewart and myself, get us connected with the right people and bring us to where we are today. So we appreciate you, Renee. And our project receives support from the WVU Humanities Center and the James and Shumway and Lizbeth Pyle Health Humanities Fund, which should allow us to go to Pain Week back in September. We're very appreciative of that opportunity. It is a national conference that allowed us to get feedback from researchers and practitioners in several related fields. So we're very grateful for that support.
So I mentioned before, all the rabbit holes. And we as educators, academics tend to like those rabbit holes and sometimes get lost. So we had to really think about where we could go with next steps, and we actually came up with a whole list of things. So one of the things that we had thought of from the beginning was looking to expand this and see if other hospitals do it better, do it differently. How do other hospital systems, health systems do opioid agreements? We did look over them briefly, but haven't analyzed them. I'd be surprised if they were any lower in the literacy level. But it will help us gain a better knowledge of the country at large. And then also looking at how do patients really look at these? My guess would be that this is just a means to an end, and they don't actually maybe not understand or maybe not worry about what's in the opioid agreement. So that's another way that we could move forward with the research. Then also looking at the use of readability formulas and other scholars that may have different ideas. I know that Canyon and Amy have gone to other conferences and have gotten great feedback. Then also looking at the differences in readability formulas and those with required payment, how do they differ? Are they better? Are they worse? Are they the same? Like when Amy and Canyon said that the smog and the flashing tape had such vastly different results, and also the online tools had different results, it was like, oh, okay, so it really depends on which. And I think that that's an online tool problem in general when we're looking at online tools. Then also looking at including researchers from other disciplines. So we had at the beginning, when we were on our rabbit hole search, we had talked about including somebody from the School of Law to look at if, okay, so do we need to do it this way? Are we doing it for us? Are we doing it for the administration? Are we doing it for the patient? And where do the lawyers, yes, and yes, not to forget the insurance companies that do help us practice medicine. And then just looking at an interdisciplinary research methodology. Our little group is strange, wonderful, exciting,
Special.
Like I think all sorts of like great adjectives. Those are adjectives, right? Yeah. To describe this group, and I would hope that other people start to find this like really happy place, because it makes me grow every day, and I look forward to our every other week Friday morning meetings. Because it brings more perspective to my home, and it makes me remember that we're all different and we all learn different things, and that's what the true meaning of interdisciplinary is. It is working towards a common goal. So we have this lovely picture from Pain Week that we wanted to share, and we thought that we'd take this opportunity to talk about, like, give 2 or 3 sentences about what we've taken away from this research as an interdisciplinary team. So one of the things I've taken away from is really being in awe of other disciplines, other educational models, and other schools, and learning about the world that Amy and Canyon live in. Because I've been in medicine for and I haven't left it. So I don't even know what other people's worlds look like. And they're really fascinating. And I think that they make me a better human and also a better physician every day. That's what I'm doing.
I mean, my favorite part of this is probably along the same lines as Dr. Holbein. Probably, top 5 favorite roles in life. Being a student is one of them. I love being a student. I love learning. I like the whole process from like opening the book with it kind of crackling as it opens to like sitting in the library and reading for days, which doesn't happen that often anymore. But so kind of learning more about literacy and how we apply that for our patients. I think in medicine we're so busy, and there's so many, it's constantly evolving, and we're constantly like learning new computer programs and learning how to document differently and learning how to build differently, and keeping up with new diagnoses and new treatments for diagnoses. So it's really easy for some of the things that happen day to day to kind of fall into this tunnel vision, I think, for us. And so it was really inspiring for me to be able to like expand my tunnel vision a little bit with this project through the education that Amy and Canyon have provided to us. So that was really, it was very cool, and it was inspiring for me. So it's exciting, and they're a lot of fun.
I know there's something else that you remember too.
What's that? Oh, I don't even want to talk about Google Slides. Amy.
So we have
That was a learning process. I did not appreciate it this much, but I'm sure I will someday.
Your address
I
is
will
hard.
someday. don't always succeed, but. I think for me, I mean, I'm a very early career physician, so I was grateful for this really opening my eyes to the opportunities that we have here at the university to really reach across other disciplines and how much better that has made this research and really added so much depth to this that we would not have had otherwise. So I'm very appreciative to that and of the friendships that we made. You know, we like each other because we meet at 7:30 in the morning, and I wouldn't otherwise do that. So, very grateful to be part of this group.
Thanks. I will echo the sentiments of my colleagues here, and then I'll also add that for me, research is a call to action, right? And I think that by leveraging the expertise in this group, we have the potential to really hopefully improve things for other people, and that's our goal here. So it's really made me think about, as educators, how we're communicating with our colleagues in other disciplines, especially around the areas of reading and literacy. It's also made me think about our students and our pre-service teachers here at WVU and how we're helping them sort of prepare their own students for not only reading for fun, which we hope everyone does, but also for these really important and sometimes, a lot of times actually, life-changing decisions. So it's been a good opportunity for me to reach across the university here and get to know some folks in other places, and our findings, I hope, will contribute to improved practice for all.
So I, of course, would say everything that they've already said, but I would also add that I think I found it very humbling to work with the group and step outside of literacy education for a bit, because there were times when Canyon and I would look at data and we would say, okay, we're gonna present it on Friday morning or show it in this way. And they would look at it and they would say something, and after the meeting, we would look at each other and say, I don't know what they're talking about. So it was extremely humbling to have to come back the next week and say, we need you to rephrase that so that we can understand it, to talk about it through the analysis phase, which they were happy to do. But the other part that was very interesting to me, because I work with mostly educators in K-12 settings, so when we would present the data, we would say, what do you think? And the three of them would just sort of take off and talk about it within their fields and what they do every day, which makes perfect sense. And we got to sit by and just sort of watch that happen. And it was really interesting work because it informed everything that we were then pulling through our system and processes to bring back the following week or two. So I just found that to be a humbling space, because normally in education, we're the leaders and we have to sort of take a step back and let these folks talk about, you know, what they know on things. So that was fun.
So, thank you for joining us. We've really enjoyed talking about this topic, and as you can see, we're all passionate and just excited to move forward with this. I think my hope is to continue for a very long time until I retire doing this kind of research, but also to hopefully have
I'm gonna learn a lot about readability.
I mean, I think it's super interesting. Like, it's this question of like, okay, so I know, like, deep down inside, you're like, this is wrong, or this just doesn't feel good, but I still need to do it. So like, what do I do about it? Will this research be impactful, and how can we ensure that? Because
like decrease barriers between, you know, patients and providers, because, you know, not understanding, you know, if we're in the same room but having two totally different conversations, that's a huge barrier to care and also to a relationship, because it's a relationship that you have, every provider has with every patient they see. It's a relationship. So the more barriers we can remove from that, this being one of them, the better.
no, I love being introverted.
We do a lot of this in our seminary meetings. So.
Yeah, But we do
We do pretty well. We do pretty well.
some days more, some days less. So I don't know, I think, like, looking back, I wouldn't change anything about what we've done, and looking forward, I'm so excited about the future. So thank you again.
I have one more thing.
Oh,
Sorry, I just want to close with thanking those who started the fund as a graduate student, as a PhD student, and hopefully, I don't want to speak for Steph here, but hopefully she'll agree. Those funds were super helpful in getting us to Vegas to share work, to seek feedback from colleagues in the field, and it was just a really great experience, and it wouldn't have been possible without you. So I just want to make sure that you know how much that meant to us as emerging scholars as well. Thank you.
So one question to wrap up.
Yeah, questions?
If you had one piece of advice for future people who may be supported by this fund, what would your piece of advice be to them working in the health humanities?
I mean, I think for me is find something that makes a difference. Like I think this makes a difference. Looking at the written documents we're giving our patients and making sure that they're understandable, because patients will read these and if they don't understand them, not everybody will ask you to further detail, you know, what's happening in this document, what does this mean for me? Now, a lot of people do, and we can have that conversation. But if we're handing them a written document optimally, like they're able to read that document and they're able to walk away with the same understanding that I have when I hand them the document. So I think that for me, it should be applicable.
Find research that you love, because you're going to be spending a lot of time with the people and reading the things that you're passionate about. And if you don't love it, then don't do it, because it's going to be tedious. But I think the love for this intersection is easily found.
Yeah, and I would just add to leverage the resources available in your colleagues at the university. I mean, Amy and I wouldn't be able to do work in medical literacy without people who work in medicine. And so I think that, you know, we all have our own skills and expertise. So leveraging those in a way that's mutually beneficial and hopefully, like I said, will improve future practice is always a good thing. And don't be afraid to go into those 7:30 meetings and say, I have no idea what you're talking about, because that is the nature of interdisciplinary research.
I mean, I don't have much to add besides that, but I feel like knowing what the research question is, besides loving what you do, you have to know what you're looking at as an interdisciplinary team, because what we're interested in is probably different than what you all are interested in, and being able to meet in the middle and say, well, what does this mean to you all? Okay, this is what it means to us. You have to have that trust in your colleagues to have that open conversation, because as you were saying, we have had a lot of rabbit holes where we're like, well, what about this? Well, what about this? And they're all very interesting little pathways, but we've got to figure out what's going to be the most impactful to then move to those other pieces. Thank you.